Welcome to the Lipids Virtual Education Summit presented by the Johns Hopkins University School of Medicine at CardioCare Live. My name is Dr. Michael Blaha, and you are tuned in to a live session called Clinical Implications of Hypertriglyceridemia with Dr. Michael Miller. Dr. Miller is Professor of Medicine in the Division of Cardiology, Professor of Epidemiology and Preventive Medicine at the University of Maryland School of Medicine in Baltimore. He's also Director of the Center of Preventive Cardiology for the University of Maryland Medical System and Staff Physician at the VA Hospital in Baltimore. Before we get started, I'd like to remind our audience that we'll be taking questions in real time throughout this presentation. You can send me your questions anytime during the program in the box in the lower left-hand side of your screen. I would like to thank Lilly USA, Amarin Pharma, Merck, and Amgen for their support of this important educational series. Please remember to complete the quiz at the end of the session to secure your CME credits. Once again, my name is Dr. Blaha, and thank you for joining us today. Dr. Miller?
Thank you, Mike. Pleasure to be here. And this is a topic of immense interest, as you know, and we anticipate the new guidelines coming out later this year, hopefully, and we'll see how triglyceride is placed into the scheme and the management of hyperlipidemia in general. But I just wanted to remind our audience of the importance of hypertriglyceridemia and the clinical implications. So to start off, the first slide really goes into the pathophys from the recent American Heart Association scientific statement. And what that shows is basically after consuming a meal containing dietary fat, that fat is processed into particles that come out into the venous circulation. These are triglyceride-rich particles that are known as chylomicrons. And those chylomicrons under normal physiologic conditions only last in the circulation for moments, after which time they're rapidly broken down by lipases, principally lipoprotein lipase. And the bottom line is the downstream particle through this hydrolysis are cholesterol-enriched remnant particles or chylomicron remnants. States in which there is hypertriglyceridemia can also stimulate the output of VLDL from the liver. And again, VLDL is hydrolyzed by lipases, and the ultimate result are cholesterol-enriched remnant particles. And so this slide, as we filter through the principal components that we believe may be atherogenic are not the triglycerides per se, Mike, but they're the cholesterol-enriched byproducts, or these remnant particles, which appear to be avidly taken up by macrophages, almost in the way that LDL that has been modified can be taken up, except these cholesterol-enriched remnants do not need to be oxidized. They can be taken up in an unoxidized manner. And so we think that why triglycerides are important is not the triglycerides per se, but the company they keep. And if we look at the prevalence of high triglyceride in the United States, as shown in this slide, we see that about 1 in every 3 adult men and women have a triglyceride that is at least 150. Levels that are viewed as high are at least 200, it's about 1 in 6. And then the folks that we get really most concerned about because of the increased risk of pancreatitis are those that have triglyceride levels that exceed 500 and even into the thousands, about 1 in 100 here. I think it's important for the listeners that, especially those that live in the southwestern U.S., that Mexican Americans appear to have a higher prevalence of hypertriglyceridemia in the United States than other cohorts. If we look at the basis for the epidemiologic association between triglycerides and coronary disease, what we see is that, by and large, looking at an array of studies, the largest tertile of triglycerides compared to the lowest tertile does appear to confer an increased risk of at least 70%, give or take. What's important to recognize, however, in a paper that came out about a year or two ago, actually now 3 years, is that after you control for HDL, which is often inversely correlated with triglycerides, and then you super control for non-HDL, of course non-HDL contains VLDL, you actually attenuate the association. So asking the question, is hypertriglyceridemia clinically important? We'd say it is, but after you involve some of these other confounders, you do lose the potency of triglycerides of themselves. So I think it's reasonable to look at the components related to hypertriglyceridemia, what may make it more powerfully associated with coronary disease. We've already mentioned the association between high triglycerides and cholesterol-enriched remnant particles. So again, the downstream particles, the fact that high triglycerides are also associated with the upregulation of cholesterol ester transfer protein that leads to these triglyceride-rich LDL particles that are avidly broken down to small, dense particles. I think we all believe that LDL is bad. Now, there's some thought that having lots of LDL particles in the circulation is probably a bit more atherogenic than less number of LDL particles. And then the question is whether or not a hypertriglyceridemic HDL may, in effect, be less efficient in reverse cholesterol transport. So the association between triglyceride elevation and cardiovascular risk is increased, but again, not because of triglycerides in of themselves. I think this slide accurately portrays what we may anticipate in individuals who may be at elevated risk, owing in here to insulin resistance, which drives a free fatty acid flux to the liver to stimulate hepatic VLDL overproduction. And again, when you have lots of VLDL circulating, CETP is activated, and that CETP then allows for the transfer of triglycerides in exchange for cholesterol ester. And so you have triglyceride-enriched HDL and LDL then avidly metabolized or catabolized by lipases. And ultimately, you have the small, dense HDL and small, dense LDL particles, which as a metabolic consequence may also reflect perhaps some of the elevated risk that has been associated with high triglycerides. We're now going to go into why we believe that triglyceride raises risk. And I think we've known, even when I was a medical student, we learned that having a high triglyceride, with the exception of raising the risk of pancreatitis, doesn't really relate to extreme cardiovascular risk as compared to high LDL, for example. What does seem to promote risk, however, is the combination of high triglycerides and high LDL. And I think this is nicely demonstrated on this slide, which shows that at every level of LDL, having a high triglyceride, defined here as at least 200, does elevate risk by upwards of twofold or greater. So the combination of high LDL, high triglyceride appears to increase risk more than high triglycerides or even more than LDL, barring a monogenic abnormality in LDL cholesterol. And I think this slide puts it all together. What I want to demonstrate here is looking at the clinical trials and not to look at the therapy associated with reduced risk, but the placebo group. So if you look at the placebo groups in the 4S trial, the folks that had coronary disease in Scandinavia and had high LDL, or the study in Helsinki, the placebo group with a triglyceride of greater than 200, shown on the right of the panel, or in the bezafibrate study, shown also with high triglycerides. What you see sticking out in all of these studies is the placebo group, and that placebo group is a combination of high triglyceride and high LDL. So left untreated, this group appears to be associated with the biggest risk. A nice editorial by Peter Libby a few years ago, I think really put this all together very nicely by demonstrating the fact that, again, oxidized LDL is atherogenic. It promotes cytokine signaling pathways, NF-kappa B here, but so does VLDL, and VLDL that contains ApoE3 enriched particles also appears to promote inflammation. So having the combination of VLDL, even enriched in C3, as well as LDL, appears to be particularly pro-atherogenic, so more so than either alone. Why C3 appears to be atherogenic in addition to its pro-inflammatory response can be shown actually just the opposite effect in a paper that looked at a mutation found in the Amish. And these affected Amish had a C3 deficiency to a genetic defect in the ApoC3 gene and causing a stop codon. And what resulted was a low fasting triglyceride. So you see here that the Amish tend to have low triglycerides. The average triglyceride, as you see here in this Amish cohort, was well below 100.
Well below 100, yeah.
But the affected individuals had triglycerides levels of about 40 or 50. And that was associated with reduced coronary calcification. I know, Mike, you've been heavily involved in understanding the epidemiology of coronary calcification.
It's an incredible marker of the burden of atherosclerosis. Yeah.
And so look here, these individuals, these Amish individuals who had this defect in ApoC3 resulting in low triglycerides also had a reduction in coronary calcification. Again, lending support to the idea that some of the company that high triglyceride keeps appears to be more atherogenic than triglycerides per se. So at the current time, ATP3, don't know if it's going to be ATP4 or it's going to be a new name associated with the guidelines. I guess we'll wait and see over the course of the year. But the current recommendations as it relates to triglyceride is that the primary recommendation is not to use triglyceride as the primary route for treatment unless the levels are really high.
Like well above 500.
Well above 500. Again, to avoid or reduce the risk of pancreatitis. Realizing even if your triglycerides above 1,000, the likelihood of pancreatitis is only about 10 to 20%. But still, obviously, because of the devastating sequelae related to pancreatitis, it is clearly something we want to avoid. And therefore, ATP3 recommended that that becomes a primary treatment. Triglycerides are lower specifically if the level is somewhere between 200 to 499, then we would consider triglycerides, not per se, but non-HDL. So you get to your patient's LDL goal, and if the triglyceride remains residually elevated at this range, then you would focus in on reducing on HDL.
So that's a good opportunity for a quick question I'll have. So the guidelines, the ATP3 guidelines, would say that if the triglycerides were greater than 200, really we should aim for that non-HDL goal. What about triglycerides lower, above 150 or above 100, where we already see some disconnect between the Friedwald calculated LDL and a direct LDL measurement that influence on the particle size? What do you think about lesser values of triglycerides?
Well, I think many of us believe that even lesser degrees of triglyceride elevation still may be associated with some degree of remnant increase in atherogenicity. The problem here, and this is kind of a recurrent theme that we face, is how important it is it to drive these numbers down per se in reducing risk. So this kind of remains the unsolved question, if you will. Should we be intensive in reducing risk based on the epidemiologic studies? And the answer is, I don't think we have enough support, even though I agree with you that levels probably in the low hundreds, mid-hundreds may still raise atherogenic risk, especially if there's some degree of LDL elevation.
So what would we consider the optimum triglycerides?
Right, so the optimal triglyceride level is a level that was set forth in the AHA statement, which is a level above 100. Right. Now that level is based on observational data.
Where the risk starts to go up.
Right. The actual, among the first studies was the Baltimore Coronary Observational Long-Term Study, the Baltimore Colt Study. That's before the Ravens were in town. And as our good friend Dr. Blumenthal remembers quite well. But this study did show that individuals that had coronary angiography done in the 1970s, spearheaded by Dr. Tom Pearson when he was at Hopkins, and then those individuals followed for about 15 or so, 18 years even, had evidence of increased cardiovascular events if their baseline TG was above 100. There's also some thought based on the work that Melissa Austin and Ron Krause have done, showing that particle concentration, particle composition is affected at elevated triglycerides, and that number appears to be somewhere between 80 to 100, so that as your triglyceride level exceeds that number, then you start to see more
atherogenic particles,
more atherogenic particles.
Concentration, yeah.
Exactly.
We have a couple questions I thought I'd get to real quick. Some interest in the Amish cohort that we talked about. One question that came in from our viewers. One viewer was curious what the LDL was like in the Amish cohort. Since the triglycerides were quite low, as we mentioned, what were the LDLs like?
Yeah, the LDL levels were not high. The LDL levels were within range. I'm going to say the levels were somewhere between 100 to 120, 130.
Right, so not terribly elevated. Okay, and another question came in. This is a little looking into the future. The question came in, what about ApoC3 inhibition? What's out there in terms of inhibiting ApoC3?
Right, and I think there is some interest in modulating ApoC3, and there are now perhaps even in early phase trials looking at inhibiting C3 through some compounds that are being evaluated, but nothing for prime time
Sure,
yet.
nothing for prime time. Something in the future, certainly something to think about.
And I think we do have, even as a final slide, we'll talk about some of the considerations for novel therapies. This would be a consideration.
Okay, great.
So the recommendations as they stand today, and as we've discussed, is to consider non-HDL as a secondary target in those individuals that have triglycerides between 2 to 499. And the primary recommendation, of course, is related to these lifestyle measures, because we know that weight reduction, exercise, modifying the composition of one's diet might ultimately translate into 20 to 50% reductions in triglycerides. So quite nice effect in lowering them. In fact, this slide shows nicely some of the practices that we as clinicians can take. And I know many of us who have treated patients that have high triglycerides, it is quite gratifying when your patients do make these lifestyle changes, especially weight loss can have a dramatic effect. It's quite disappointing many times for LDL, because you may get about a 10% lowering of LDL, but triglycerides, not uncommon to see 30, 40, 50% reduction.
Yeah, absolutely. It's very gratifying.
And if you take this all in tandem, so you have the weight loss, you have the changes in Mediterranean lifestyle, so more monos versus saturated fats, and reducing carbs. Because as you increase the carb component, that stimulates VLDL production. You need about a high carb diet, so about 60% carb diet appears to stimulate VLDL output.
Right, and seems to track with insulin sensitivity, right? As we improve insulin sensitivity from lifestyle measures or diet measures, start to see triglycerides improve.
Also, that's right. So they all work pretty effectively. So lifestyle really does play an important role.
Here. Yeah.
And so that is one of the nice things that we can say to our patients that really does work. The effect of the Mediterranean diet on cardiovascular disease, stroke, and death from disease is shown here in a paper that just came out recently, showing that the major endpoint, that is myocardial infarction, stroke, or death from cardiovascular disease, was beneficially influenced in individuals who had subscribed or had been randomized to a Mediterranean diet. You know, olive oil, some nuts, beans, fish.
More olive oil, more nuts, more fresh fruits and vegetables. A little bit different than the traditional low-fat diet put forth by the AHA.
Yeah, my favorite nuts are pistachios. I don't know, what are yours, Mike? Do you have any favorite nuts?
Almonds and walnuts.
Both good source. Yeah. Walnuts, of course, being a good source of linolenic acid, the omega-3 linolenic acid.
Right.
The statement on triglycerides as it relates to pharmaceuticals show that there are several that can lower triglycerides. Fibrates, effective, niacin, fairly effective, the omega-3 fatty acids as well. And statins, of course, will also lower.
Right.
And it turns out, even if you look at some of the earlier statin trials, you tended to get more of a TG lowering effect the higher the baseline TG. Right. So it's a kind of makes sense for that. For omega-3, it's a little bit different. We do see an approximate 5 to 10% reduction in triglycerides at varying levels for about each 1 gram of the intake of omega-3. And both EPA, icosapentaenoic, and docosahexaenoic acid, they both lower triglycerides. These are, the next few slides will discuss where some of the clinical trials have, I believe, shown the most efficacy, specifically in the fibrate trials. And the fibrate trials showed that subjects with dyslipidemia, and we'll define dyslipidemia here as high triglyceride, low HDL, got the most bang for your buck. Right. And this is a conglomerate of a cohort field, as well as the Helsinki Heart VA hit. What's interesting is that if you did not have high triglycerides, low HDL, shown on the right side of the slide, you really didn't gain any benefit at all. So it appears that in the fibrate-treated patients who had high triglyceride and low HDL, they benefited. Of course, the shortcoming is that these studies were not specifically designed in a hypertriglyceridemia population.
So that gets us to a question that we got in from our audience. One of our astute listeners said, but don't recent trials say that reducing triglycerides don't matter? So I think it's worth reiterating that point. So, a cohort enrolled patients that didn't necessarily have extremely high triglycerides, or triglycerides could be as low as 130. So the patients that you and I probably talk about treating the most, the low HDL, high triglyceride group, which is reflected in the left panel of your slide, that subgroup is the one I think we talk about the most, and that's where you did see, albeit in a subgroup analysis, a benefit. So it might be a little bit more complicated of an answer to say, well, maybe trials that treating triglycerides don't work. There's probably some caveats there.
There are definite caveats. Now, in the Accord, compared to the other fibrate trials, there was a pre-specified a priori analysis in the hypertriglyceride low HDL group. So that was pre-specified, it wasn't post hoc. The other ones were post hoc, which of course are just hypothesis generating, but the pre-specified does lend some credence to the notion that fibrates may in fact be effective in the hypertriglyceridemic low HDL group, although again it wasn't the primary hypothesis. And that's been kind of viewed as the shortcoming.
Yeah, it's viewed as negative in some ways, but I think many of us aren't looking to treat a triglycerides of 130 always as aggressively as we would that person with severe dyslipidemia.
Right, but this would be concordant with what the current guidelines recommend.
That's right.
Triglycerides above 200, you get the LDL down to the target goal. This is reasonable. Get non-HDL down, and sure enough, fibrates would be a reasonable approach. AIM High is a study that we participate in, and the AIM High study, as I think most of our listeners know already, was that came out a couple of years ago, was negative. A number of patients here, about 30, somewhere in the mid 3,000 range, and they did have a tendency to high triglycerides and on average and low HDL. Again, not super high triglycerides, but still high enough. On the mean here, as you see, or median was in a range that would be viewed as kind of borderline, if you will. But the study, one of the ideas of the study was that most of the patients coming in the trial had been pre-treated with therapy. The majority on statins, and about 1 in 5 already on niacin. So if you're a believer in the idea that taking a statin for a period of time will stabilize plaque if you're at risk, may reduce your overall risk, then putting somebody on a statin who's already been on it for years over a relatively short period of time.
Yeah, that's right. It seems to me a different substrate when you take people that are pre-statin treated that might have delipidated plaque and so forth. And of course, AIM High is a confusing trial to interpret with lots of different interventions competing with each other, and certainly not a triglyceride-specific trial.
Right. It was not a triglyceride-specific study, and it was really a study looking on taking individuals who really, on treatment, had a really good LDL.
That's right.
And this is kind of perhaps the biggest obstacle we face right now that we didn't face when I got into the field 25 years ago. And that is we already have great therapy in the form of statins and obviously some of the other therapies we use now. But putting statin as our foundation, how much more of a boost can we get using numbers of patients that are not particularly high? AIM High was only about 3,500. And so a recent, perhaps to look at the low HDL, high triglyceride, the higher triglyceride group, there was a sub-analysis that my colleague John Guyton did, and this looks at, this has not been published yet, but it was presented at AHA last year, and this in fact shows us that those individuals that had triglycerides of at least 200 and a low HDL did fare a little bit better. Again, this is post hoc, but they did fare better in this analysis. If you just looked at the tertiles, the upper and lower tertile, they were, that's at the top of the screen, that is above at least 198 versus less than 33. They certainly trended in this area. So again, in concert with the fibrate studies, a high triglyceride, low HDL group in these analyses does suggests that there may be benefit.
Yeah, and it comes back to what you said before. Triglycerides, it really matters the company it keeps, right? We're talking about a dyslipidemic pattern, not an isolated hypertriglyceridemia as much as that dyslipidemic pattern like we see here in this sub-analysis, which we see all the time in clinical practice. That's not an extreme dyslipidemia. We all treat that all the time.
We treat that. We tend to be more proactive. And in effect, you could see here that what's really interesting in aim high in the sub-analysis is that LDL levels on average were about 70. Mm-hmm. So you're still having a good effect, and you're still able to get a little bit of a bump.
That's right. In those people whose ApoBs probably are still a little bit higher, who have that residual.
Exactly. Exactly. That so-called residual risk that we've been trying to tease out for the last few years. The largest study that came out, not published yet, but presented, was HPS-2 Thrive. And this study looked at about a little bit over 25,000 patients. But look at the baseline lipids here. What you would see, again, is that this group at baseline, yes, they had their HDL level, well, it wasn't quite as low as an aim high, and the triglycerides weren't quite as high as an aim high. But look at the LDL. So the LDL here at baseline is in the 60s. So again, how much are you going to be able to overcome the effect if you're starting off with an LDL that's low? And what we see here was that there was no difference between the groups, even adding extended-release niacin and the PGD2 inhibitor, laropropant.
Yeah, which of course adds a little bit of murkiness to the picture of the prostaglandin inhibitor. We all don't know exactly what to make of that, but nonetheless a negative trial.
Yes, a negative trial. And if you look at the significant excesses of adverse events, a lot of the patients in this trial had not been on a statin before. You're putting them on a combination of statin and niacin, and many of these were Asian. Mm-hmm. And we've known for some time that Asians may be a little bit more sensitive to combination, and that appears to have been brought out by this. So let's move on. So we have suggestion in the literature, at least, even if it's not pre-specified, except with the exception of Accord. But we do have some suggestion that high triglycerides, low HDL benefit. What about the omega-3s? You know, we had some of the earlier trials with omega-3s that suggested that a low dose of, like the GISI Prevenzione study, showed 1 gram's worth could reduce sudden death. Of course, that study was done in the 90s, and at that point, not very few people were taking statins, but they did see an effect with 1 gram. Moreover, these were not hypertriglyceridemic patients. So the question has come up, what about looking at patients with omega-3? The JELA study was done in Japan, and again, importantly, it was not a hypertriglyceridemic cohort. But they were interested in asking the question as to whether the addition of omega-3 in folks that already eat a fair amount of fish on top of a low dose of a statin, Pravo or simvastatin, might reduce risk. And it turns out in JELUS that there was a 19% reduction in cardiovascular events. The majority of the individuals here were at risk of a first event. About a quarter were repeaters, so recurrent events. But the results here was a 19% reduction in risk in events. And after 5 years, you see here the percentage just to show you the control versus EPA only, that you see the percent change in baseline cholesterol levels, not that much of a difference here. Actually, triglyceride levels on EPA alone, this is 1.8 grams a day, didn't really have that much of an effect. Again, probably because these were not hypertriglyceridemic folks to begin with.
That's right.
What was interesting, again, let's go to the subgroup analysis, some recurrent theme, and the hypertriglyceridemic low HDL group, very nice effect here, 50% reduction. But again, no specific grouping of individuals starting out. So the study was not testing the question.
That's right.
Taking individuals that have high triglycerides and then assigning them to placebo or your compound.
Yeah, that's right. That really hasn't been tested at all just yet in that specific group, unfortunately, I think a lot of us think.
Right, and hence, Mike, I'm glad you brought that up because there is a clinical trial that is being conducted now, and the clinical trial is called Reduce It. And this study is asking the question as to whether or not individuals that have either vascular disease or at high risk by virtue of having diabetes or at least one risk factor, having the atherogenic dyslipidemia, do they benefit on top of standard of care? So it's an extremely important question. I'm on the steering committee for this study. So we're excited about it because this is a study that, quite frankly, should have been done a while ago. Yeah. But it's being done now, and and its anticipated completion is in about 2 or 3 years.
Oh, great. Yeah.
So it's exciting, and patients are being randomized around the world as we speak. These are the selected outcome studies. So Mike, again, to just illustrate some of the studies that have gone on in recent years, you have the GISSI study, we talked about that, 1 gram a day. You have the Origin study that came out about a year ago, looking at diabetic individuals or pre-diabetics that were then assigned as one of the groupings to omega-3. Didn't really have a significant benefit here either, but again, these were not specifically hypertriglyceridemic individuals. The JELA study did look at folks, but again, not hypertriglyceridemic, at about 1.8 grams. The Reduce It study is looking at hypertriglyceridemic individuals and using a good dose. So we're going to ask we're asking, I think, the right question and using, I believe, a dose that will hopefully answer this question in a more...
produce a benefit in the lipids, enough that we could expect a benefit.
Exactly.
If the hypothesis is true.
Right. If we're going to get a 20 to 30% reduction in TGs in individuals that have baseline TGs of 220, 230, 250, I think it stands a better chance at answering this question, resolving this issue. Of course, we don't know the answer, but we would like to believe that we're asking the right question here. This, Mike, is our final slide, and this talks about some of the newer therapies that are being considered to reduce triglycerides. We've already talked about the purified EPA compound, but there are also inhibitors of DGAT. That DGAT is in the pathway between triglycerides, monoglycerides to diglycerides, and diglycerides could branch off into triglycerides, the triglyceride pathway, or to phosphatidylcholine, the phospholipid pathway. So DGAT inhibition might be one way to drive towards phospholipids as opposed to triglycerides. Then we have MTP inhibition, and this would reduce the output of VLDL, microsomal transfer protein, that's involved in putting the machinery of putting the lipoprotein together. We have the PPAR agonists that are under testing as well. We have gene therapies, and there's even this ApoC3 that we've alluded to. So I think that's an exciting area, and we just wait to see if we can just get right at it.
And of course, this is an exciting area, and it's increasingly important, of course, right? Because we all see in our practice that obesity is going up, the metabolic syndrome is going up. Probably the fundamental lipid abnormality in the metabolic syndrome is an overproduction of triglyceride-rich VLDL, right? So this is very a timely question, and probably actually more important now than it was ever, in my opinion.
Right, and especially since we all recognize that mixed hyperlipidemia is not a trivial issue. It is really important. Our endocrinologic colleagues, our diabetologists see this all the time, but we, even the coronary care unit, even seeing our patients with acute coronary syndrome that we follow up, mixed hyperlipidemia remains the most common lipid abnormality phenotype that we encounter. So, and it doesn't have to be, and I think the point to be stressed to our viewers is it doesn't have to be a triglyceride of 400 or an LDL of 150. It's just a touch of LDL elevation and a touch of triglyceride elevation that tends to spur on perhaps this pro-atherothrombotic potential.
Maybe we'll go to a quick question real quick. This was a good question that came in from one of our viewers. One of the viewers said, Are you still recruiting for the Reduce It trial? And how can people get involved? Is there still avenues for people to become involved in the trial?
Yes, Reduce It is actively recruiting. There are a number of countries that are participating in the trial right now. So I would recommend that this listener go on to the Reduce It website. I think if you just plug into Google Reduce It study, you'll get all the information to direct you and how you may find the site that may be closest to your patient who may be, he or she may be eligible for enrollment.
So I have a question. I think this would be a topic that maybe our listeners might be thinking about. So, there's a lot of talk about fasting versus non-fasting triglyceride measurement out there right now, and a lot of us still do fasting lipid profiles, of course, but there's instances where we get non-fasting samples. What's your perspective on fasting versus non-fasting hypertriglyceridemia, and what are the implications of each?
Sure, I think that's a very relevant question, especially in view of some studies that came out several years ago that suggested that non-fasting triglycerides may be a better predictor of risk compared to the fasting levels. Well, it turns out, and in the AHA scientific statement, it is recognized that fasting triglycerides have been used for many, many years, but it doesn't have to be that way, because as long as your patient comes in and does not have a whole lot of fat before at their breakfast, because we all know patients come in and they may come in, see you in the morning, they may be hungry and they have to get their blood drawn. But it turns out that if you eat less than 15 grams of fat in the morning, then the likelihood of any appreciable triglyceride elevation is very low. So in the scientific statement, it is said that consumption of up to 15 grams a day would be reasonable. So if you don't have any fat, obviously it's not going to have a major effect. So yes, non-fasting triglyceride levels are now recommended, provided that there's not a lot of fat that's consumed prior to those, especially in the morning if you're going to have, because triglycerides will last. What happens is you eat some fat, triglycerides, as we noted before, converted to chylomicrons. You get a peak, depending on how much fat you consume, but somewhere between 2 to 4 hours. And of course, the problem is over the course of a day, we're eating, digesting, absorbing, and so our levels go up, up, and then down. The only time we ever have our lowest triglyceride, of course, is the fasting triglyceride, but that really doesn't represent our physiology, where we're living throughout the course of a day. What we can anticipate, however, is that the higher your fasting triglyceride, the greater the bump postprandially. There's a pretty good correlation. In fact, the best predictor of the postprandial triglyceride effect is your fasting triglyceride level. So it's not uncommon in patients that are coming in, and you've seen these patients as I have, patients that are coming in, and this is kind of one of the quirks that kind of get concerned about. A patient will come in and say, "Doc, I went to a screening fair. I had a non-fasting triglyceride. They said it was 300. I went back to my doc, and he said, well, it's 300, don't worry about it." And of course, I worry about that.
Yeah, sure.
Because if you're doubling your triglyceride levels, and if we're saying the ideal triglyceride fasting is probably somewhere below 100, what we expect is even if you have a large, heavy fat meal, it really shouldn't double or more than double.
I think this is an important point, because at least I see this mistake made sometimes in a primary care clinic, for example, maybe where the lipid profile is disregarded because it wasn't fasted. But you're right, that your insulin-resistant state, your triglycerides at baseline are really a predictor of that triglyceride rise after a meal.
Right, and in truth, nobody should ever have a triglyceride of 300-400. Right. It's not physiologic.
That's right.
I don't care how much fat you've consumed. It tells you something is physiologically awry, and it needs to be looked at. And then, of course, you would get a fasting level just to see what. But anybody who comes in with a non-fasting triglyceride of 300 is off.
Yeah, it's telling you something metabolically about that patient. A good question came in from Carl in our listening audience. So, what about PCSK9 inhibitors? I know those are out on the horizon. They're certainly in phase 3 trials now. and certainly the pathway is familiar to us, dealing with the LDL at least. But what about, let's talk about triglycerides as it pertains to PCSK9. What do we know about those inhibitors?
Right, I think as in the case of statins, I think we know that there is can be a mild reduction in triglyceride levels as well, and perhaps due to the pathway of VLDL output, if you believe, it's not only the upregulation of LDL receptors, but the idea is how much of this PCSK9 may also affect how VLDL is made and the extent to which you may have some mild reduction in triglyceride.
Right. We've got a few more questions. Let's look at a question from Lawrence out in our listening audience. Let's see, Lawrence asks once again about the REDUCE-IT trial. He said, in REDUCE-IT, will LDL be adequately treated? He says, do we know that the residual risk will not be related to inadequate LDL therapy? So kind of teasing out once again this question of LDL or ApoB elevation versus triglyceride lowering itself. How would you answer that question?
Absolutely. Well, patients in the study are placed on standard of care therapy with the initiative, and there are specific guidelines within the protocol for the principal investigator to act if the LDL, first they will be alerted if LDL levels are out of range. But even beyond that, the idea here is to provide best care. So all patients here are taking statins and good LDL lowering therapies.
Right. So, okay, let's look at some more questions. We have a question from the audience. So this is from Michael Shapiro. Asks, how much did triglycerides decrease with this drug is here is called it's vamidipide. Is anybody saying that right?
Right.
Yeah. Once again, one of these emerging. Do we know anything about triglyceride lowering with vamidipide in clinical trials?
Yeah. Again, I believe that triglycerides are lowered, but again, the indication for lamidipide would be in individuals that have high levels of LDL,
right?
Like
so
either a homozygous FH or a homozygous FH.
So not something that we'll be thinking about clinically, but once again, something else on the horizon. Let's see if we have another question. Once again, we have a question here that says, David asks, I aim LDL to be less than 70 in my non-diabetic patients whose triglycerides are around 150. Am I being too rigid with that patient?
Yeah, this is, again, one of the areas that we just don't have enough information to put forth specific recommendations. And so if you're measuring LDL particle number through NMR technology, for example, while that appears, certainly in observational studies, particle number appears to be a good predictor of risk. We just don't know whether lowering particle number above and beyond our standard indices, especially LDL, confers improvement. Tested tested as a primary approach.
So let's talk a little bit about lipid measurement. Certainly most of us, all of us, get standard lipid profiles, and whether we get fasting or non-fasting we've discussed. In the hypertriglyceridemic patient, do you see utility in measuring LDL particle number or ApoB?
I generally will reserve it for our research purposes, and here's why. What happens is we know that in hypertriglyceridemic individuals, they will tend to have lots of small particles, so particle number will increase.
Right.
ApoB levels, by definition, should also increase. And so if you're doing a research study asking a question as to the effect, but there is heterogeneity in the population. So it's not to say that everybody who has a triglyceride of 180 will have 75% of their circulating LDL particles as small and dense.
Right.
I mean, there is going to be a range there. But it's a good poor man's measure of assessment. I'd like to see data to show that more intensive treatment of these individuals makes a difference.
Right.
And I think that again, so again, from the standpoint of research and understanding how those particles might behave, I think it's very important. But from a clinician standpoint, I think the jury's still out.
Right. Yeah, that's a great point. So let's talk a little bit about, I guess, the guidelines that may or may not be we'd be seeing soon. Or certainly we've heard recently that the NHLBI might be disavowing themselves a little bit from this process and passing it off to the AHA. But maybe without too much speculation of what we think we might see, what do you think we're going to see regard to the issue of triglyceride, hypertriglyceridemia in the new guidelines? Will it be similar to the ATP3, or what do you think?
Yeah, I think, unfortunately, obviously, I've been interested in triglycerides for a long time, but I just don't think, if the Institute of Medicine has placed the onus upon evidence-based medicine, then there's no reason to believe that triglycerides would make up any significant part. If any, you could even argue maybe there won't be anything about triglycerides in the guidelines. You could even argue maybe there won't be non-HDL in the guidelines, because the only proven modality is with statin therapy. That is even more so than LDL lowering, because the studies were really not specifically, prove it perhaps being one exception, but even there you got to read between the lines, but it's really, the studies were really driven on statin therapy.
That's right. So this is I think, a really interesting topic to discuss, right? Those trials picked a patient population perhaps defined by maybe age or a cholesterol number and gave a fixed dose of statin, but never titrated to a particular LDL level or cholesterol level or triglyceride level for that matter. So in this movement towards strict evidence-based criteria for guidelines leaves us in an interesting situation, because there's all this observational data that says triglycerides are bad. There's data showing the subgroups with high triglycerides and low HDL perhaps benefit more from therapy, but there's been no, as of yet, prospective randomized control trial looking at getting triglycerides down to a number, or ApoB down to a number, or a mixture of drugs to achieve a target. So it leaves us in a difficult situation, I think, what to do with the guidelines. Like you said, if they're strictly evidence-based, maybe it would just say, find a high-risk patient, give them a statin. And that's pretty much all it would say.
And I think that would be the most logical if you interpret IOM as they're based on what they're suggesting. Now, what may happen is that they come out with, NHLBI comes out with a statement on lipids as well as blood pressure, et cetera, based on evidence-based medicine, which might just be statins, and then send it off to different committees like ACC, AHA, and then from there, the gray zones come into kind of clarity. And they might recommend, well, we don't have clear data right now, but it might be reasonable to consider in these patients until the data proves it or disproves it.
So a question from one viewer in our audience, a good question. What about hypertriglyceridemia in the setting of renal failure? How does that change your therapeutic decision making?
Right. So hypertriglyceridemia in that setting is quite tricky, clearly, because fibrates, which are among our most powerful potent tools, really would not be used, especially if they have really low creatinine clearance. So if the creatinine clearance is below 30, I'm not going to use a fibrate. Niacin therapy, again, niacin has been, used for so many years, and even in patients that had renal issues, but hepatic was fine, would have been used. But now, in the absence of good clinical outcome data, it's hard to recommend that in the absence of these patients developing pancreatitis. So I think if they've already developed pancreatitis and they're at risk of pancreatitis owing to super high triglycerides, then I think you would put forth the argument that they should be treated. Other than that, it's really a matter of deciding on the proven therapies, even triglycerides so high.
So this issue of kind of patient populations and side effects I think is always interesting. We hear all the time that maybe statins cause more muscle side effects than reported in the trials, et cetera. And of course, a lot of the time we're talking about statins and a fibrate or another drug. What is your take on muscle complaints in the combination of statins and, in particular, fibrates?
Well, yeah, and my colleague Paul Thompson is, has written a lot about this. It's statins causing a true myopathic process, or more appropriately, rhabdomyolysis is uncommon.
Right, that's very rare.
We've seen cases. I had a patient years ago that had Crohn's disease that was just on gemfibrozole and had rhabdo. But by and large, we don't see cerevastatin being the outlier with the high doses of cerevastatin, which is no longer on the market. But by and large, we don't see a whole lot of rhabdo, but I do see a lot of patients. Probably the biggest referral to my practice is either hypertriglyceridemia or patients that have complaints of muscle achiness, normal CKs, by the way, virtually always normal CKs. But you take them off the statin and the pain goes away. And so that's when we start to consider some of the off-label uses of statin therapy, like twice a week, 3 times a week. But I think it's real. I think if a patient complains to you that they have bilateral symmetric, especially proximal muscle-related achiness, it's real. And even with normal CKs, I will take them off and give them a holiday.
If they're already on dual lipid-lowering therapy, how will you manage that patient? Will you take them off both drugs? Will you take them off just the triglyceride-focused therapy first and leave the statin, or how do you manage that?
Yeah, and again, it all depends upon what their clinical sequelae have been. So if I have a patient who's on combination therapy but had pancreatitis, I might, ultimately some of those folks might end up getting plasmapheresis if their triglycerides are super high. But I would take them off both statin and triglyceride-lowering therapy, get them feeling better, and then reinitiate probably statin.
So I'm figuring some of our viewers probably have questions about over-the-counter omega-3 capsules that a lot of our patients take. A lot of them come and take a capsule or 2 a day for various things that they've read on the internet or in the news. What do you tell patients who might be taking a couple fish oil capsules a day but might have borderline triglycerides?
Well, remember, the prescription therapies are only approved by the FDA for triglycerides above 500.
That's right.
So if you have patients that, and then the concern is pancreatitis, as we've talked about. So if you have patients that have lower triglyceride levels and are taking an over-the-counter, I will tell them that over-the-counters, as you know, they're not really scrutinized by the FDA. Right. They're not basically, there's batch-to-batch variability, et cetera, et cetera. Yeah. Still, they're inexpensive, and but if you're going to take one capsule that has about 300 milligrams of EPA, DHA, for example, it's not going to do a whole lot for your triglycerides. So you would need multiple capsules. You would need the equivalent of 3+ capsules for each one of the prescription. But
and I always like to say this comes back to lifestyle too, right? So make sure they're getting enough omega-3s in their diet and making good lifestyle choices with their diet first. And once again, bring us back to the issue, of course, lifestyle. We've talked a lot about pharmacotherapies, but lifestyle is critically important in these patients. If we can make a big difference in their lifestyle, we can also make a big difference in their triglycerides as well.
No question, and the point I think here as well is that for EPA and DHA, you do need to consume it through marine-derived sources. So you take your favorite kind of seafood that has a good content. Obviously salmon, sardines, good content, herring, mackerel. We used to call it holy mackerel, but now mackerel also is unfortunately a high source of mercury. So you got to balance out the mercury content with it, with some of the constituents of that you're looking to treat.
Well, thank you so much for joining us here in Cardio Care Live. And I'd like to thank Lilly USA, Amarin Pharma, Merck, and Amgen for their support of this important educational series. And please remember to complete the quiz at the end of the session to secure your CME credits. Once again, my name is Dr. Blaha. Thank you to Dr. Miller, and thank you for joining us today on Cardio Care Live.